Preeclampsia, defined as having an elevated blood pressure on at least 2 occasions, 4 hours apart in previously normotensive women, also accompanied by protein in the urine, can cause complications and even death for both mom and baby, including preterm delivery, which is birth before 37 weeks gestation. There are higher risk of complications if this is of early onset and severe. Major challenges in obstetrics today include identification of preeclampsia early in pregnancy and also interventions to reduce its prevalence. Previous studies have found that women who take aspirin in pregnancy are less likely to develop preeclampsia. Low-dose aspirin at 50 to 150 milligrams per day results in a 10% lower incidence of preeclampsia. Aspirin given before 16 weeks gestation halved rates of preeclampsia development, whereas if given after 16 weeks gestation, there was no significant effect. Benefits of aspirin are also found to be dose-dependent, with a greater reduction of preeclampsia development seen with aspirin given at or above 100 milligrams per day. Currently, it is recommended that aspirin be given prophylactically at 60 to 80 milligrams per day in women identified as high risk. Also, that combined screening of maternal history and biomarkers are shown to be most effective in preeclampsia identification. The key objective of this multi-center, double-blind, placebo-controlled trial was to test the hypothesis that, among women with singleton pregnancies or one baby, identified at high risk with the combined screening, aspirin at a dose of 150 milligrams per day, given from 11 to 14 until 36 weeks of gestation, would result in incidence of preterm preeclampsia half that of the placebo. The primary outcome measure was delivery with preeclampsia before 37 weeks of gestation. The main finding was that the intervention did significantly lower the incidence of preterm preeclampsia compared to the placebo. In the sample of 1,620 women, preterm preeclampsia occurred in 1.6% of participants in the aspirin group, shown in red here, and in 4.3% of participants in the placebo group, shown in blue here. There were no significant differences between the aspirin and placebo group in regard to demographic characteristics, medical history, or the occurrence of adverse events. I must also note that this intervention did not reduce the risk of term preeclampsia or preeclampsia development after 37 weeks gestation. Overall, the authors recommend administration of aspirin at 150 milligrams per day from 11 to 14 until 36 weeks gestation in women identified as high risk. I must lastly note that the funding agencies and aspirin and placebo distributor had no role in this trial design or the research process.